Medurstand-Understanding Medicine.
I'm Professor Aziz Rehman from Medurstand-Understanding Medicine. And today I'm going to talk about this fairly common condition, acute chest pain. Since this is usually an emergency, so I think you need to be well versed with this condition and how to approach, and I'm going to primarily focus on acute coronary syndrome because that is potentially a serious condition and that is fairly common also. And when patient comes, I think most probably what he or she wants to know is if this is cardiac pain or other pain. So I think first question is, if somebody comes with acute chest pain, first I think of course on history and on physical examination, first thing you'd like to decide is if this is non-coronary or coronary. Many times, and this may be all you want to do, and if this is non-coronary, it may be simple musculoskeletal pain, and but if this is coronary, then of course it is potentially serious. So there are a number of things which can suggest that this is non-coronary. Non-coronary, of course, is a big group, but I've just included those conditions which are common. So these are the features. If somebody has chest pain and has any of these or multiple of these features, this would suggest a non-coronary cause. For example, if pain is localized and there is associated tenderness, and pain increases on certain movements and it radiates to occiput or it radiates to below umbilicus, because pain of coronary artery disease does not radiate through these areas. And if the pain is nagging, lasting for several hours, or if it is associated with numbness, so pain in the chest which radiates to the shoulder and arm, but there is numbness and the pain is nagging and for very many hours, so that is unlikely to be coronary etiology. So these are the things, if present, they would suggest the coronary cause. That means acute coronary syndrome. If pain is diffuse, not localized, it is diffused and central, like here, pain is diffuse and central, pain is constricting in nature or is pressure like feeling. So that, and if there is typical radiation, you know, pain of acute coronary syndrome could radiate to the epigastrium, it could radiate to the back, it could radiate to the shoulders and either arm, or very, very specifically, it could radiate to the jaw. So if that is the case, and if especially if there is sweating and palpitation, very, very high chances that this may be coronary. Now, very important, I think we always consider this fact, if patient is a high risk patient, then even atypical pain should be, at least you want to rule out coronary artery disease by appropriate test. So high risk patient, somebody who is already a known case of coronary artery disease, somebody who is a smoker, somebody who is diabetic, somebody who is hyperlipidemic, somebody who is obese, somebody who has family history of ischemic heart disease. So all these patients are high risk patients. Even moderately suggesting symptoms should be investigated. But if patient is a low risk patient and the symptoms are not typical, then maybe you can just reassure the patient and send him home. Now, the pathogenesis of acute coronary syndrome. You know, patient may have certain risk factors. This is the vessel, and at the cross section they show how this disease progresses. Somebody may have risk factors. I just mentioned them, and those risk factors, they lead to oxidation of low density lipoprotein molecules, and they cause atheromas. And these atheromas, they are very common, and many times they are not causing any symptom. Of course, if there is critical narrowing, it could cause angina, but there are many patients who have significant atheromas, but they do not have any symptom because the plaque is still covered by smooth endothelium. But there may be some inflammation. Maybe many times we do not actually are able to find out what is the cause of that particular inflammation. Could be infection. So inflammation leads to rupture of the cap, and that releases certain thrombogenic factors, and the raw surface exposed that attracts platelets, and that causes thrombosis. So this is the process. At this end, patient may not have any symptom, and this complete occlusion, patient may have transmural myocardial infarction, and here patient may have unstable angina or NSTEMI, non-ST segment elevation myocardial infarction. So I think early action would mean that you can prevent this blood vessel from getting completely occluded. So what are the tools of assessment? Of course, we have history. A careful listening to the patient will tell you if this is acute coronary syndrome. In fact, 90% clue comes from the history. So history is very, very crucial. You should take a focused history. And then ECG. ECG is another tool. ECG can show you very, very important findings, and you can immediately make a diagnosis, or ECG can rule out a coronary event. So ECG is very, very good, and especially because it is usually available in the emergencies, can be done anytime, and it takes just 1 or 2 minutes to record the ECG, and you just need few seconds to look at it and make a diagnosis. And then troponins are also important. Many times we have to do troponin to see if there is myocardial infarction. So I think if you use these 3 tools, you can surely handle most patients with acute coronary syndrome, and you can diagnose which category do they fall in. So evolving syndrome, acute coronary syndrome is an evolving, and if you intervene early, you could actually prevent it from getting worse. So if somebody has prolonged and resting ischemic cardiac pain, that is acute coronary syndrome. So I'm going to highlight the pathophysiology. So there could be a case where there is atheroма, and there is rupture of atheroma, and there is a small clot formation that has caused some narrowing of the blood vessel leading to ischemia, but no infarction. This is myocardium, so there is no infarction. So since there is no infarction, there would be no ST segment elevation. ST segment elevation occurs only when there is transmural infarction, and troponins will also be negative. So this is called unstable angina. That person has acute coronary syndrome, but that would fall into this category, unstable angina, no actual myocardial necrosis. Second category is if the thrombus is slightly bigger, it may cause more critical ischemia, and that might also cause non-full thickness infarction. This yellow part is actually infarction. It is not through and through. It is just part of the myocardium. So this type of infarction does not cause ST segment elevation. So there will be no ST segment elevation on ECG. But since this is infarction, and troponins will be elevated. So this is called NSTEMI, non-ST segment elevation myocardial infarction. Okay. So if troponins are positive, then you can use the word myocardial infarction. When troponins are not available, you would use the word acute coronary syndrome. In third category, if the patient is a little unlucky or presented late, there may be completely occlusive thrombus, and it may cause transmural infarction, full thickness infarction, and full thickness infarction would cause ST segment elevation. By the way, I have separate videos on ECG which would explain this concept in much more detail, how this transmural infarction causes ST segment elevation and how this non-full thickness infarction does not cause ST segment elevation. So this would cause ST segment elevation, and troponins will also be positive. So this will be called ST segment elevation myocardial infarction. So just these 3 tools, history, ECG and troponins, you are able to differentiate between 3 subtypes of acute coronary syndrome. And it is important to differentiate between the 3 because the prognosis and the immediate treatment may be different. So this is the three-step approach. I'm going to sum it up again. First of all, you take history. Of course, you don't want to waste time. If patient complains of chest pain, you want to remain focused on the chest pain and associated symptoms. So on the basis of history, if you think that this is ischemic chest pain, and next thing you do is to record an ECG. And I think as a physician, you should learn how to record an ECG also. There may be a situation where you do not have an attendant, you may not have a nurse. So I think you need to learn how to record an ECG. So ECG can give you immediate diagnosis. In fact, when you're recording and ECG paper is coming out, by the time ECG is recorded, you already know the diagnosis. So first possibility is that in a person who has got typical history of chest pain and ECG shows ST segment elevation. So if ST segment elevation is there, you need to have significant ST elevation in at least two contiguous leads to be significant. So if there is significant ST segment elevation, this patient would be labeled as ST segment elevation marked infarction, and this patient would follow a certain trajectory. I think this patient should be moved to emergency setting, ideally the cath lab, for immediate revascularization, reperfusion. So other possibility is that the ECG does not show ST segment elevation. So please note down, I just said that no ST segment elevation. ECG may show some changes, may show ST depression, or may show some other T wave inversion, or maybe normal. But if the pain is suggestive of acute coronary syndrome, but ECG is normal, then you do not want to rule out ischemic event. It could be either NSTEMI, which is non-ST segment elevation marked infarction, or it could be unstable angina. So both are potentially serious conditions. You don't want to miss them. So you need to do further tests, and the further test is troponins. So troponins, they become positive. They are actually cardiac biomarkers, and previously we used to do cardiac enzymes, but troponins are better in all respects. So they are more specific, more sensitive, and the newer generation troponin assays, the fifth generation assays, they become positive in just 2 to 3 hours. So I think best is you would do troponins at the time you receive the patient, even if patient is reported within 2 or 3 hours. Traditionally, we used to wait for 5 hours, but the new assays, they become positive in just 3 hours. So you would like to do a troponin assay on the bedside at the time of arrival. If that turns out to be negative and patient has got just few hours history, then you would like to repeat it before you say that patient does not have ischemic heart disease. So troponins may be positive. If they're positive, that means there is myocardial infarction, but non-ST segment elevation type myocardial infarction. It is non-full thickness infarction. And if troponins are normal, but patient has ischemic heart disease, then it would be called unstable angina. Patient with unstable angina, they have different treatment than NSTEMI, and people with STEMI have got different treatments. So it is important to be able to differentiate between the three conditions. So that was the diagnostic algorithm. Now I'm going to talk about the management algorithm. At the time of presentation, these are things which you would like to do all of them. It is not possible to give you a certain a sequence. So whatever you can do, I think you should do. For example, you should ask the patient to take sublingual glycerol trinitrate. And you should also administer 300 milligram of soluble aspirin. It should be soluble aspirin because you want immediate effect. Enteric coated aspirin may not be very good here because that will take long time before it starts acting. Then clopidogrel 300 milligram. Even if patient is a known case of ischemic heart disease, even if patient was already on antiplatelet therapy, it is recommended that you should give a bolus dose of 300 milligram aspirin, 200 milligram clopidogrel, along with sublingual glycerol trinitrate. If patient contacts you on telephone and you suspect ischemic heart disease, acute coronary syndrome, you should instruct the patient to take these medicine before moving to the hospital. Now then oxygen is given as a routine. IV line should be secured because all emergency patients they need IV line. Morphine or nalbuphine should be given 10 milligram. In literature you'll find morphine, but morphine is a controlled drug, may not be available in private clinics and hospitals. So nalbuphine is actually equally effective, and same dosage that is available, you could use nalbuphine. And then you would also do ECG monitoring if you have the facility, and pulse oximetry should also be done. And you should get an ECG and troponins as soon as possible. So all these things, if you're alone, you should do all of them one by one. And if you're a team, one person can give medication, the other can pull the ECG and start recording, another person can start monitoring. So all these things should be done as fast as possible. So after this, if patient turns out to be a case of, if there is no ST segment elevation and troponins are also negative, provided patient has history of 4 hours and 4 or 5 hours and troponin is still negative, then this is unstable angina. So as per guideline, these patients may not be admitted and they just need stabilization by nitrates and heparin infusion, and after 24 hours they may be sent home. And if there is no ST segment elevation but troponins are positive, this is NSTEMI. And if ST segment elevation is there and troponins are also positive, this is STEMI. In both these categories, we need to do the reperfusion. Of course, there are multiple ways of doing reperfusion. Best is PCI. So I'm going to now take up these two conditions, STEMI or NSTEMI. So primary aim of the treatment is reperfusion. So we have pharmacological methods of reperfusion and we have intervention, percutaneous coronary intervention. Of course, these two are effective, but if facility is available and if a trained person is available and patient reports to a place where this is available, then primary PCI as a first attempt to reperfusion to reperfuse the myocardium is the best. But sometimes we try pharmacological therapy like streptokinase. If that doesn't work, then we have to try PCI also. So ultimately, many patients they would require coronary artery bypass grafting, maybe later on or maybe in the same setting. So I think we need to consider that also in some cases. So these are various methods. I'm going to take them up one by one. First of all, pharmacological intervention. Nitroglycerin or isosorbide dinitrate infusion, antiplatelet aspirin and clopidogrel, heparin, low molecular weight heparin or fondaparinux, these are all useful. And then thrombolytic agent. I think this is very, very important because all these can either save the ischemic myocardium and or prevent further clot formation, but thrombolytic agent can dissolve the existing clot and can reperfuse the ischemic myocardium. So I think the maximum emphasis should be on the use of thrombolytic agent. In our country, we have just one such agent available, that is streptokinase. So you need to know about this, and thrombolytic agent, and 1.5 million international units should be infused intravenously over 1 hour. Previously, it used to be given slowly, but these days we try to give it as fast as possible, usually within 1 hour. It is recommended that physician or a trained nurse should be present on the bedside because this drug can cause some side effects and those side effects may require immediate attention. And watch for complication, rule out contraindication, and I think once you have done that, patient may become better. So this slide now describes the other methods of intervention, that is PCI, percutaneous coronary intervention. This is of course the treatment of choice. The problem is that this is not available everywhere. In fact, even in developed countries, the possibility of intervention is not always there. But let's discuss it in more detail. So there are three types of intervention, PCIs. One is primary. when you opt to do PCI as primary modality to reperfuse the myocardium. Second is elective, when patient is treated with pharmacological therapy in the acute setting, but sometime later, whenever that patient can get an appointment, electively PCI is done. Then rescue PCI, that means pharmacological therapy was tried, but that didn't work. So as an emergency, patient was offered PCI. So PCI basically means angioplasty, cardiac catheterization, balloon dilatation of narrow vessel, and then usually there is the stents are placed. It could be bare metal stents or drug eluting stents that are placed, so they would actually be more long-term and durable solution. And in some cases thrombus is removed, that is called thrombectomy. All are covered under the term PCI. So third possibility is coronary artery bypass grafting, and either as an emergency procedure or later on as an elective procedure, this may be more definitive solution of reperfusion. There are indications are critical narrowing and where PCI either not possible or PCI has failed. And there are venous grafts or there are arterial grafts. Arterial grafts are used if somebody has a well-developed internal memory artery that is attached with the coronary artery distal to the narrower part. So that is best graft. Otherwise, the venous, the saphenous vein is taken out from the same person's leg and that is grafted. So this actually shows the two types of, suppose this is infarction and these are the two types of graft. This is venous graft from aorta to the vessel distal to this right coronary artery. This is arterial graft. This is internal memory artery attached to the coronary artery. So these are two types of grafts. Of course, further details are beyond the scope of internal medicine. So after you have manage a case with acute coronary syndrome, these patients need to be put on certain medication to prevent further recurrence. Aspirin should be prescribed, and many times we give aspirin and clopidogrel, both at least for 1 year. Statins should be prescribed even if patient does not have hyperlipidemia. High intensity statins are recommended. High intensity statin means atorvastatin 80 mg or rosuvastatin 40 mg, and in our country we usually give half of that. 40 mg of atorvastatin or 20 mg of rosuvastatin is considered high intensity statin. Then control of risk factors like smoking, diabetes, hypertension, they should all be controlled. So if this turns out to be a non-cardiac pain, there are various possibilities. There are some potentially serious conditions also in this group, like dissection of aorta is serious, pulmonary embolism, pulmonary infarction may be serious, rupture of esophagus can be serious, pericarditis, pneumonia are also potentially serious. So you should be able to differentiate and diagnose these conditions. A relatively benign condition like reflux esophagitis, costochondritis, pleurisy, musculoskeletal, herpes zoster, I think if ECG is negative and if the troponins are negative, patient may have, and other tests are negative, then patient may have just one of these and a painkiller or a reassurance may be enough. So how do we manage non-coronary conditions? These are the investigation which may be required. X-ray test is very, very useful. An X-ray test will rule out many non-coronary conditions. So D-dimer may be done to rule out pulmonary infarction. CBC may be done to rule out pneumonia. CT chest may be done if you suspect some other lung disease, or upper GI endoscopy may be done if you suspect esophageal problem. And the treatment may be IV non-steroidal anti-inflammatory drug. I love this salt called ketorelac, very, very effective painkiller and very easy to give, and omeprazole and others as per need. So I think non-coronary patient, of course, this is a big group and one lecture cannot cover all these conditions, but I think some reassurance will be given and these treatment will be given. So that concludes my talk on the management of acute coronary syndrome, acute chest pain. I hope you found it useful, and I really look forward to see you in my next video. Professor Aziz Rehman from Medurstand-Understanding Medicine.